The House Health Policy Committee will come to order. Would the clerk please take attendance?
Chair Vanderwall.
Present.
Representatives Thompson.
Present.
Meerman. Tisdall. Bierlein.
Here.
DeBoer.
Here.
Preston.
Here.
Schmaltz.
Here.
St. Germain.
Here.
Bonak.
Here.
Frisbee.
Here.
Witset. Carter.
Here.
Whitwer.
Here.
Neely. Hoskins.
Here.
Foreman.
Here.
Mr. Chair, you have 13 members present. You do have a quorum.
Thank you, Madam Clerk. Representative Whitwer moves to adopt the minutes of the March 12 meeting. There being no objection, the motion passes. Today we are going to be hearing testimony on House Bills 4072 and 4101 through 4104. First up, we'll hear testimony on 4072, introduced by Representative Steckloff. Representative, if you could make your way up to the testimony table, I appreciate you being here. If you just give a quick minute, I would like to introduce a school that's here today in the audience from Concordia University, their OT program. Thank you guys for being here and what you do. I appreciate that. Hopefully you'll learn a lot, but the importance of you pursuing a career in the health field is greatly admired by every one of us here today. And don't be shy if you have questions after the meeting today. Any one of us would be glad to take that, but my office is always open. So thank you very much for being here. And with that, Representative, the floor is yours, and we look forward to your testimony.
Thank you, Chairman Vanderwall, members of the committee. Thank you for the opportunity to testify on this issue that impacts both the financial burden on patients and the efficiency of our healthcare system. Many of you recall our testimony from last year on this bill, and I appreciated your time then. This bill was brought to my attention by a dedicated constituent who's an ophthalmologist. During his residency in Illinois, where his practice is already law, he witnessed firsthand the benefits of allowing patients to take home their prescribed medications. Upon moving to Michigan, he was stunned and perturbed to find that such a sensible practice was not in place here. You see, currently, when a patient requires treatment with these medications during their stay, any unused portions are discarded when they leave the facility. Consequently, patients must then obtain a new prescription, go to the pharmacy, get the exact same thing they were already taking just to continue their treatment at home. Often, this incurs additional costs and facing potential delays in receiving their medication. By not allowing patients to take their prescribed eye drops and ointments home, we inadvertently increase the financial burden on our healthcare system and our constituents. So it's time for Michigan law to evolve to meet the practical needs of our residents. Let's employ some common sense here and modify our regulations to permit patients to take home their eye drops and ointments when they have already been prescribed them starting use during their medical care. This change will streamline treatment. It reduces both the cost for the patients and the healthcare industry and minimizes medical waste. Just a few months ago, this exact bill passed this committee and also passed out of the House floor 108-1. And so I thank you all, so many of you that are on here, for your support. And let's get the finish line together for our residents and our neighbors. And following this testimony, you will hear from some of our esteemed ophthalmologists who can provide technical details and insights further to elaborate the benefits of this proposed change. And thank you for consideration and commitment to the people of Michigan.
Well, thank you, Representative. Any questions from the committee before we move on and hear the next one? No questions. All right, Representative, I think everybody wants to wait to the next one, or you did just that. Great. Thank you for being here. Next up, we'll hear testimony from Dr. Scott Westhouse. He is a retina specialist speaking on behalf of the Michigan Society of Eye Physicians and Surgeons. Dr. Westhouse, thank you for joining us, and please begin when you're ready. He's on Zoom, is that correct?
Yes, I am on Zoom. So
Very
Chair
good.
Van
The floor is
Wall,
yours.
Vice Chair Thompson, Vice Chair Witset, and members of the committee, thanks for your time.
Thanks for the opportunity to speak to you today. Thanks too to Representative Steckloff for introducing this bill. I'm here to advocate for House Bill 4072, which, as Representative Steckloff said, will permit hospitals, emergency rooms, and outpatient surgery centers to send home eye drop medications with patients. As a state society at Michigan Society of Eye Physicians and Surgeons, we believe that this is critical to saving patients money, also ensuring accessibility to critical medicine, reducing medical waste, and optimizing our healthcare resources. I should mention I'm a retina specialist in Grand Rapids. I've been in West Michigan for 14 years. As a retina specialist, I'm an ophthalmologist trained and as a physician, and went through residency in ophthalmology and then an additional couple years for fellowship for retina. So this is something that I encounter daily with my patients and will encounter later today. The reason I'm on Zoom here is because I have to head to the operating room after this. I had to shuffle my schedule around. So I also want to thank you for allowing me to do this via Zoom. So what does this bill fix? As Representative Steckloff said, it will ensure that topical eye medicines or drops that are used for patient care within the hospital, emergency room, or surgery center can be taken home with a patient if they need it for their continuing care. Currently, there's a large disposal of unused eye drops that significantly increases patient costs and also just medical waste to our system. I think I'll key in on three separate issues that I see and also give you a little bit of a statistic here on potential amount of money saved with this. So in 2019, there was a report that was done through ophthalmology that evaluated waste in surgery centers just surrounding a single cataract surgery. And they found with a single cataract surgery, the average in their cohort was about $148 of unused or partially used medications that were discarded per case. For your understanding, this is in 2019, so that cost is probably higher now, but in 2019, there were 3.8 million cataract surgeries performed in the United States. So that's $560 million if you extrapolate that data, $560 million of discarded medications following cataract surgeries per year. So I think we can agree that there's a lot of money to be saved here, but we also want to focus on the patient experience and the quality of care that they're receiving in this. So let me give you 3 examples where we see this. Number one issue, the most common, is cataract surgery. In my book, it's with retina surgery, but for all of these surgeries, patients, I've got eye drops here. Before surgery, they'll receive a dilating eye drop, the red cap. They'll receive an antibiotic eye drop. And then many times they'll also receive anti-inflammatory eye drop, almost like an ibuprofen eye drop for the eye. They receive that before surgery. They have the surgery, they go home, they typically follow up on one-day post-operative visit, and they're prescribed many of the same medications. The exact same medications that were used at surgery that had to be thrown away, they then have to go to their pharmacy, pick up those same drops, take them to the office, and then they receive their instructions on how to use them. So cataract surgery is by far and away the most common area that we'll see this, where costs could be saved and patient experience would be improved. The second situation is actually a scary situation, and that's in the emergency room. Acute glaucoma is one of the reasons patients will present to the emergency room in severe eye pain, and they can lose vision quickly. Their pressure gets too high in these situations, and they're put on a host of eye drops and sometimes oral medication to quickly lower their eye pressure. Once their condition is stabilized, they're sent home, oftentimes with eye drops that need to be used every hour to 2 hours to keep their pressure low, or it will go right back up. And these are medicines they received in an eye drop bottle was opened, it was used, patient goes home, has to go to the pharmacy, get the same medication, and use it frequently. There's an issue with delay of care. Sometimes the local pharmacy isn't open. Sometimes the local pharmacy doesn't carry the medication. And there's delay in treatment, and potentially that patient's eye pressure goes back up. The third situation is in the hospital setting. So patients will go to the hospital for a non-eye related problem. Say they're admitted to the hospital for a stroke. They undergo a stroke workup, they land in the hospital for 2 or 3 days. While they're there, they're started on their home medications. One of their home medications, let's say, is an eye drop for glaucoma. They can't take their home medications to the hospital, so an order is put in for that eye drop medication. Patient gets 2 days worth of the medicine of a bottle that lasts 30 days, and the rest of that bottle is discarded and thrown out when they go home. This bill would allow them in all those 3 situations to receive the counseling that they need, labeling instructions would be given, but the patient would actually be allowed to go home with their medication. It would increase compliance, reduce the burden on the patient, reduce the burden on the system. One of the other things I'll quickly touch on is where we stand environmentally. We live in a society that's all about reuse, reduce, recycle, and this is another good example of where we can be doing a better job. So Representative Steckloff mentioned in Illinois that this is available. So in 2021, Illinois passed a bill for this. Our bill is modeled off from that bill, so this can be done safely and effectively. Proper guidelines and protocols can be established to ensure that only safe and appropriate eye medicines are going home with a patient. Clear instructions and education can be provided to the patient to ensure they understand how to use and store their medications. This is already practiced by many ophthalmologists elsewhere. In closing, I just want to say that allowing these eye drops to be sent home with patients is practical and it's a beneficial policy change. It aligns with our goals as a state organization of reducing medical waste, lowering costs, enhancing patient care, and improving healthcare efficiencies, while also promoting environmental responsibility. We at MySuch urge the committee to support this legislation and take steps towards a more sustainable and patient-centered healthcare system. I'd be happy to answer any questions that you might have, and thank you again for your time.
Thank you, Doctor. I appreciate it. I know there's a few questions. We'll start off with Representative Thompson.
Thank you, Mr. Chair. First of all, I want to thank Representative Steckloff for reintroducing this common sense legislation, and I want to thank you for giving your testimony. I think that it's about time that we get to using these common sense practices in healthcare. As a nurse that has administered this medication, I understand the original concept that if the tube were to touch someone's eyes, it could become contaminated and you need to throw it away because only that person needs to be using it. So some of the opposition that we've heard against this legislation is that it's going to give a healthcare worker one more task to do with dispensing the medication and versing the patient in the safe application of the medication. Can you talk about that a little bit and tell us, frankly, how ridiculous that opposition is to this?
Yeah, so we're giving that So I could see an argument if it's one bottle that's being used among multiple patients, but we're talking about the same bottle being used for the same patient. These patients are using similar eye drops all the time, and we don't have any issues with that. And so there are instructions that we give as physicians when we send patients home with eye drops or start them on new eye drops. This would not change anything with that. We would be following our typical standard of care.
Thank you very much.
Next, we have Representative Bonack.
Thank you, Doctor, for presenting this information. I think partially the issue that I have was brought up by Representative Thompson, but is there a law now that says that you can't give the medication and have that patient take it home? And what's the reasoning for that legislation? Do you know?
Correct. There are dispensing laws that prevent us from doing that. So currently we can there's an allowance for small samples of medications to be given and dispensed out of our offices or out of a hospital. But this is more than just a sample. It's more volume. It's not a 1 to 2 milliliter bottle. It's going to be a 5 to 10 milliliter bottle. And so it technically violates pharmaceutical dispensing laws at this time.
Does that answer your question, Representative? Any other questions from the committee? I just have one. How many other states have this practice in place currently, besides Illinois?
That's a really good question. I don't know the exact number of states. I know it's been done in Virginia as well. I don't have the total number of states, but I can get that information for you.
That would be great. All right, we'll see no other questions for you. I appreciate your time, and we wish you a good day at work, and hopefully it's productive for you. Thank you.
Thanks, everyone.
A few cards I'm going to read in on House Bill 4072. Not wishing to speak in support of the bill, Monica Martinez, Michigan Society of Eye Physicians and Surgeons. Brett Jackson, not wishing to speak in support of the bill, Michigan Health Purchasers Coalition. And not wishing to speak in support, Kate Dorsey, Michigan State Medical Society. Thank you. Next up, we'll be taking testimony on bills 4101 and 4102, introduced by Representative Bierlein and Representative Fitzgerald. Welcome both of you to the testimony table. And you've been through this drill. When you're ready, the testimony table is yours, and if you can make sure your mics are hot, that would be greatly appreciated. And we look forward to your testimony. Thank you.
Good morning, and thank you, Chair Vanderwall and members of the committee for the opportunity to speak today in support of these bills, which I've introduced alongside Representative Fitzgerald to bring Michigan into the Physical Therapy Licensure Compact. I want to recognize Rep. Fitzgerald's work on these bills last term and his continued dedication to improving access to healthcare services in the state of Michigan. As Michigan continues to face workforce shortages and increased demand for healthcare services, including physical therapy, we must seek innovative solutions to improve access to care. The Physical Therapy Licensure Compact provides a structured and effective way to address these challenges. Currently, 32 states have joined the compact, allowing physical therapists and physical therapist assistants to practice across state lines with greater ease. By becoming a member state, Michigan will expand opportunities for licensed professionals while increasing access to essential therapy services for our residents, including those in rural and underserved communities. House Bill 4101 establishes the Physical Therapy Licensure Compact within Michigan's Public Health Code and outlines the necessary framework for participation. Under this legislation, licensed physical therapists and physical therapist assistants in Michigan will have the privilege to practice in other compact member states without needing to obtain multiple state licenses. Under these bills, Michigan will be required to participate in the compact's data system, ensuring efficient verification of licenses and compliance with national standards. The state will maintain oversight through the enforcement of background checks, continuing education requirements, and adherence to compact regulations. Protections will still be in place to ensure that only qualified professionals with clean disciplinary records are granted compact privileges. Active duty military personnel and their spouses will have additional flexibility in designating their home state for licensure purposes, making relocations easier for our service members. By passing this bill, Michigan will join a growing number of states working together to streamline licensure processes while maintaining strong regulatory standards. This will reduce administrative burden for physical therapists and physical therapist assistants looking to participate in multiple states. It will improve workforce mobility, helping to address shortages in healthcare providers, and it will ensure public safety through comprehensive data sharing and oversight mechanisms within the compact. Joining the compact is a proactive step forward, strengthening Michigan's healthcare workforce and expanding access to care for our residents. 4101 ensures that our state remains competitive in attracting and retaining skilled healthcare professionals while upholding the highest standards of patient safety and professional accountability. Thank you, and I'll pass it over to Rep. Fitzgerald.
Thank you, Chair, and esteemed members of the committee. I appreciate the opportunity to be here today. I'd also like to thank Representative Bierlein for his interest and passion for this legislation coming out of last term. I worked on this last term with former Representative Dale Zorn, and we believe that this is another worthy piece of policy to continue moving forward, as this did not eventually receive a vote in the Senate for passage ultimately, but we believe that this is going to help to improve and impact the lives of Michiganders. These bills are truly vital, vital pieces of legislation that will pave the way for Michigan to join that Physical Therapy Licensure Compact. These bills, as I mentioned, are reintroductions and are important components of overall health and well-being for Michiganders. Physical therapists help people manage pain, recover from injuries, assist those who experience balance issues, and even help people recover after suffering a heart attack. By adopting these bills, we enable physical therapists licensed in other compact member states to practice in Michigan without the need for an additional state-specific license. At the center of these bills are improved access and efficiency, and access to qualified therapy professionals is important in underserved rural areas where healthcare services can be sparse. By joining the Physical Therapy Licensure Compact, we can enhance the ability of physical therapists to serve across state lines, like states that border Michigan, broadening the availability of essential health services and ensuring that citizens receive timely and effective care. The compact strengthens the safety of our constituents through its robust system of shared background checks, continuing education, and disciplinary information. It ensures that only those physical therapists who are fully compliant with stringent standards can practice, enhancing the safety and quality of care. Let us also consider the flexibility these bills afford to healthcare providers, particularly in the evolving landscape of telehealth. As telehealth continues to expand, joining this compact is a forward-thinking move that aligns Michigan with the future of healthcare delivery. National and state physical therapy associations often advocate for participation in the PTLC, citing benefits such as increased professional opportunities and enhanced public protection. With this legislation, we can uplift military families who stand to benefit significantly, especially for veterans who are suffering from long-term pain, PTSD, and physical therapy can go a long way in providing relief for those who served our country. Each provision is designed to maintain the highest standards of public safety and professional integrity. Opponents of these bills have voiced concerns about potential impacts on traditional licensure revenues, but overall benefits, like the improved access, public safety, and the support for a mobile workforce, I think far outweigh those. I would like to just pick up from something the representative mentioned, which is actually 39 states have now joined the Licensure Compact, and 6 others, including Michigan, have introduced legislation to join that compact. So we do see that this is something that is widely accepted across the country. So by passing these bills, we are not just reforming licensure, we are reaffirming our commitment to the health and well-being of every Michigander, and I urge your support on these bills. Thank you, Chair, and we look forward to questions.
Thank you, representatives. Committee questions? Representative Schmaltz.
Thank you, Chair, and thank you for your testimony. I just wondered, of the 39 states that have adopted this, what difference did they see after approving this compact, and how quickly did they see a difference?
I think that's a question that might be best for our next person who's testifying, but I really believe that what you'll find, I don't know about the timeliness answer of this, but you will see that there's access, ability, you're getting more quality care, more readily available to you. We talked about telehealth, those who may be snowbirds here in the north. If you have a continuum of care, that you have a provider in Michigan, that while you're in Florida or while you're in Florida, you have somebody that when you come back to Michigan, that would now allow for that to occur.
Thanks.
Thank you. Representative Carter.
Thank you, Mr. Chair, and thank you for your testimony. I heard it a couple of times about it will improve access to rural and communities in needs. Can you please elaborate how the compact would do this?
So Rep. Fitzgerald touched on a lot of the telehealth issues that would break those barriers. The other thing is just it's a recruitment tool. Right now, if you're out of state or when we're looking for travel folks, licensure is a problem that keeps people in the states that they live in, and this just allows that access. So it's another tool for providers to bring in folks and have access to more providers.
And I might also uplift that Wisconsin, Indiana, and Ohio, so border states of Michigan, are also in the compact. And so when you talk about the western UP, the southern half of Michigan's Lower Peninsula, and then those providers who may be in northern Indiana, northern Ohio, and again that western UP section, you may have somebody who lives in Michigan but needs to seek care in Wisconsin or vice versa. It helps to make sure that we have that ability for our more rural Michiganders.
Follow-up comment.
Absolutely, Representative.
Thank you for that explanation because I'm deeply concerned about access to care in the Upper Peninsula. So thank you for that.
Thank you. Any other questions from the committee? With that, I have a couple questions, and the first one is there's always the hit of what is this going to cost the state? Is there a true cost that you guys have estimated and what this would cost the state to comply?
I don't have the number. It does require some tracking. We have to join the compact. There could be some license revenue loss, but right now I don't see that as much of an argument, to be frank, because those folks aren't coming into this state to practice. They're staying. They're not, buying a license in Michigan and buying a license in Florida and doing 6 months in each when they're at the end of that retirement. They're just practicing in one state or the other, and then maybe they, take off for 3 months. So I don't see that as an argument. This is it's an access provider.
Very good. And that was the next question to these folks. So they buy one license in whatever state that they're calling their home state that is in this compact. That's the only license they have to purchase. Is that correct?
There is also, I believe, an additional $90 fee that would actually allow them to then participate in those states. But your licensure then is good in all of those states.
Very good. Thank you. Very good. I see no other questions for the two of you. I appreciate you both being here. And the next person that is going to come up and speak, I believe, is Brian Gilbert, the president of American Physical Therapists Association in Michigan. Evie, are you joining or you're going to remain? All right. The expert is hitting. The table is yours. If you could make sure your mic is live. We look forward to your testimony. Thank you for being here.
Thank you. Good morning, Chair Vanderwall and members of the Health Policy Committee. My name is Brian Gilbert. I'm a physical therapist, current president of the American Physical Therapy Association of Michigan. I am also a private practice owner of 11 clinics in the Western Michigan area. I'm also the former chairperson of the licensing board for the state of Michigan. Thank you for the opportunity to speak with you today regarding House Bill 4101 and 4102. I really, everything that was said just previous to me, I want to thank Representative Fitzgerald and Bierlein for their leadership on this important issue. They did an amazing job of hitting all the topics that I was going to hit. So rather than wasting everybody's time, I'm just going to hit on a couple other small pieces and then take any questions that you have with regards to these bills. As an employer, we know that in Michigan we have workforce issues, as do many other employers. Although I don't live on the border of this great state, I can empathize with my colleagues who state that they have lost physical therapist and physical therapist assistant candidates that did not want to go through the hassle of attaining and retaining two different licenses. This is going to reduce that burden and improve opportunities to attract and retain talent in Michigan. I want to comment on the educational piece of this. There are 7 universities in Michigan that are educating physical therapists, as well as 10 educating physical therapist assistants. We're educating the best and the brightest students and want them to remain in Michigan after they become licensed. Passing the compact into law provides an incentive to our newly graduated PTs and PTAs to make Michigan their home licensed state. They may choose to be travel PTs or PTAs earlier in their career. However, when they return home, they will return to Michigan. We want to help stop the brain drain and make Michigan more attractive to our graduates by becoming the 40th jurisdiction to join the PT Compact. As far as the compact, improving patient access has been commented on. An example of the telehealth in the rural areas, There are examples of pelvic floor and specialty care, Parkinson's, things that require specialty training that aren't accessible in those rural areas. By having the telehealth option, or somebody who might live in a bordering state working in our state, it provides care to those individuals in those rural areas much more significantly. It does not remove the state's authority to discipline those who provide care to Michigan residents. And it does not alter the scope of practice for PTs or PTAs. PTs and PTAs who have their home license in another state must still comply with all the Michigan laws and rules for the PT profession when practicing in Michigan. It was commented upon in the military. I won't reiterate that. So I will ask for your support for House Bill 4101 and 4102. Any questions?
Thank you very much. Questions from the committee? I don't see any questions. I have one for you. Do you happen to have a number of how many of our graduates decide to exit the state of Michigan upon graduation?
I don't know that I have that number personally, as I'm more on the hiring of individuals in my area. That might be something that our next speaker might be able to comment on.
All right, very good. I appreciate it. Oh, we do have Representative Preston.
I didn't locate it in the bill, but is there a jurisprudence aspect to this for Michigan?
Yes.
There is. Can you tell me a little bit about it? The size of the exam?
To my knowledge, it's the exam itself. I don't know that I can comment, again, personally on that. Anything beyond that, I don't have that specific answer.
The full exam, if we were not included in the compact, are they going to go through the same exact exam as if we were not in the compact?
Yes, that is my understanding.
All right.
All right. Very good. I believe that Representative Rogers has that answer. She raised her hand out in the audience. If you could step to the table and when you do yours. Okay, very good. That'll be fine when you do your testimony next. Appreciate that. Thank you for being here. Next on Zoom, we have Jeff Rosa, the PT Compact, Physical Therapy Compact Commission. Jeff, welcome. Thank you for being here. And the testimony table is yours.
Well, thank you very much, Chairman Vanderwall and members of the committee. And for the record, my name is Jeff Rosa, and I am the Compact Administrator with the Physical Therapy Compact Commission. I want to thank you for your consideration of House Bills 4101 and 4102. The previous witnesses have really done a great job explaining about the compact, so I'm not going to go through all of my written testimony, which would be just repetitive of what you've already heard, but I want to highlight a few things and try to address some of the questions that members of the committee have asked. But in essence, the compact is really an alternate pathway for physical therapy providers who meet the eligibility requirements to obtain that privilege to practice in another state within a matter of minutes instead of the traditional days, weeks, or months that are associated with the licensure process. And instead of a multi-state license model in which an individual licensed in one state can legally practice in any other compact state with no notification requirements to the remote state, under the Physical Therapy Compact, when a licensee wants to work in another active compact state, which is known as the remote state, that individual must purchase a compact privilege for that specific remote state. And so in addition to the fee that the Compact Commission charges for that compact privilege, the state has the ability to charge a state fee in addition to the commission's fee, which is a way that the state can also help raise revenue that it otherwise would be losing through a decrease in endorsement licensure applications. So the compact has many benefits for Michigan, its PT providers, and its citizens. As I said, the process is faster and more efficient, so it allows for improved access and choice of physical therapy providers for everyone, especially in underserved areas of the state. Obviously, it preserves the state-based licensure system, so the Michigan Physical Therapy Board retains the ability to determine who is practicing in accordance with Michigan's state laws and rules governing the practice of physical therapy. And then also by requiring participation in the data system, it helps ensure that timely reporting of disciplinary notifications taken in another state can occur. So it ensures that idea of public protection, which is really the key purpose of the licensure compact. To try to address some of the questions that were previously answered, obviously, the typical cost that states will see is initially there may be some one-time cost if any kind of data system enhancements are needed to participate with the commission's data system. Some states, they were able to easily make these changes with little cost. Other states, there may have been a little work that had to happen. It all depends on what is the current status of the database that Lara is using, and how easily will that interface with our system. But typically that is the main expense you're going to see for a state to join the compact. The bill authorizes the commission to charge an annual assessment against states to be a member of the compact commission. Since we've been an active compact since the 2017, we have never charged that annual assessment, and really the entire operations of the compact commission are funded through the sales of compact privileges. Regarding how quickly states will see benefits, it really all depends. Some states, it took them a much longer time from the enactment of the legislation to implementing all of the requirements needed to become an active compact state. So it obviously took them much longer to see the benefits of joining the compact. Other states were able to join and then become an active compact state much quicker. And some of the benefits that we're seeing is we have people, as was talked about with telehealth and physical therapy practice, we have compact privilege holders that have privileges in 20 plus states because they want that ability to be able to treat their patients in any state that they may be located in. And instead of having to be licensed in all of those states, they now have the ability to go through the Compact Commission to have that same legal authority to provide physical therapy in those states in a much quicker, easier fashion. In the rural areas of states, as was previously said, the compact really is also a great benefit that, as was talked about in the Upper Peninsula, close to Wisconsin, there may be health systems that have presence in both Michigan and in Wisconsin. The same thing in, the Toledo part of Ohio and southeastern Michigan, where PTs and PTAs right now have to be licensed in multiple states and maintain all of the requirements to keep those licenses active and in good standing. With the compact, if they live in Michigan, they have the ability to get that compact privilege in the other states, or if they're in Ohio, Indiana, Wisconsin, they have that ability to get the compact privilege. So they have that legal right to practice and provide services in parts of the state that may have challenges getting people interested in wanting to work in those parts of the state. And anecdotally, what we hear from a lot of students is, as they are making decisions on where they want to get that first license, they are looking at, is that state a member of the compact or not? Because a lot of students, they may want to be travelers those first few years after they graduate with their physical therapy degree. And so they want to maximize that flexibility. So they are making conscious decisions that if they're going to get that PT education in a state that's not a member of the compact, they may choose not to get licensed in that state because they want the flexibility of taking advantage of the compact once they are a licensed physical therapy professional. So with that, I'm happy to answer any additional questions that the committee may have.
Any questions from the committee? Representative Preston?
Thank you, Chair. Does this compact, so I'm struggling to understand this in relation to my, so I'm dual licensed in Wisconsin and in Michigan because of my Upper Peninsula location. So does the compact replace the dual licensure requirements across the state? So if they're a compact participant, are they automatically licensed then in the states that are participating?
Reverend Preston and Chairman, the way the process would work is right now, because Michigan's not in the compact, I have my Michigan license and I also have a license in Wisconsin. Once Michigan were to join the compact, instead of needing to maintain my Wisconsin license, I can instead when that Wisconsin license is up to be renewed, I can say I'm going to let my Wisconsin license expire, and instead I'm going to purchase a compact privilege for Wisconsin. So you still, the PT compact works on the model of this home state license. So if I live in Michigan, I have to be licensed in Michigan because that's my home state. And that gives me the legal ability to purchase the compact privilege for whichever other state that I want to provide physical therapy in. So that if I lived in the Upper Peninsula and I needed to also see patients in Wisconsin, instead of having to be licensed in both Michigan and Wisconsin, I can just get the compact privilege for Wisconsin.
Thank you for the clarification.
Representative Foreman.
Thank you. So my question is, who can remove the license? So if someone is doing, telehealth or any other, or delivering care here in Michigan, but they were originally licensed in another state, which state is, and they do something in Michigan that would get their license revoked, which state is responsible for that?
Representative Foreman and Chairman, ultimately, both the state where the person is physically practicing. So in this scenario, if they had a compact privilege in Michigan and they did something to violate the Michigan Physical Therapy Practice Act, the Michigan PT Board has the legal ability to take action against the compact privilege. So typically, if they take action against that compact privilege, not only will that impact Michigan's compact privilege, but any other compact privileges they may have would also immediately be terminated. Ultimately, it would be up to the home state to determine whether or not it would take action against the license that they issued, but the state of Michigan would have the right to take action against the compact privilege, which would prevent that person from being able to legally practice in the state of Michigan under the compact privilege.
Any other questions from the committee? Seeing none, I appreciate you being here today and your testimony. And you have a great day.
Thank you very much.
All right, we have a few cards to read in. Not wishing to speak, support of the bill, Amy Heath, the Chair of Department of Physical Therapists. Not wishing to speak in support of the bill, Susie Steele, PT, PhD, Intern Project Director. Not wishing to speak in support, Todd Sander, Director of Department of PTs and Athletic Training. Not wishing to speak in support of the bill, Sarah Arena, Director of PT Program. Not wishing to speak in support of the bill, Jennifer Blackwood, Director of the PT Department. Not wishing to speak in support of the bill, Christine Reed, Academic Department of PT. And not wishing to speak in support, Taylor Elpert, Michigan Health and Hospital. And I believe we got a couple more. Not wishing to speak in support, Denise Hoffman, Michigan Occupational Therapy. Not wishing to speak in support, Concordia University of Ann Arbor, School of Health Professions. So those cards will be entered in, and thank you. From here, we will move to take testimony on House Bills 4103 and 4104. Representative Rogers, if you could make your way up, we appreciate it. Whenever you're ready, Representative, the floor is yours, and thank you for being here.
Thank you, Chair. There's a little healthy snack for everyone to start out their morning. Chair Vanderwall and members of the committee, thank you very much for listening to our testimony. We have similar bills to the Physical Therapy Compact, so I will kind of also condense some of my testimony to not be redundant. I will speak to both my bill, House Bill 4103, and Rep. Wozniak's Bill 4104, as I think he was double booked this morning, but is here in spirit, in this bipartisan package. The OT Compact is an interstate professional licensing compact for occupational therapists and assistants, which will address licensure portability as was outlined earlier. So it allows OTs to practice in all states that have joined the compact. These bills are reintroductions of House Bill 4169 and 4170 from last term, which passed the House 103-6, had a few technical changes made in the Senate, and then died in lame duck. The OT Compact authorizes a practice based on a valid, unrestricted home state license, just like the PT one. And this, again, is occupational therapists who have master's or doctoral degrees and occupational therapist assistants who have associate's degrees. As a practicing physical therapist myself who works alongside other PTs, PTAs, OTs, and CODAs, I can personally share with you that we have many, many workforce issues, just like several other healthcare professions. In fact, one of the many reasons I still practice physical therapy myself a few days a month is because my hospital desperately needs each and every one of us to pick up weekend and other shifts to help rehabilitate our patients who are in need. And when we don't have enough therapists, there can be additional hospital costs, as discharges are often delayed waiting for us to make an assessment. You see, we are often the specialists who help the medical team determine what type of setting is most appropriate for a patient to safely discharge to. And when one of us cannot make that evaluation, they sometimes get held over to the next day. And these workforce issues can have quite an effect on the quality of care for patients and on an institution's bottom line. The need for occupational therapy is not diminishing. In fact, according to the Bureau of Labor and Statistics, they forecast a 17% increase in the number of occupational therapist positions by 2030. The need is growing year over year for these services, and we must consider any and all solutions to expand workforce access for these professions. As my colleagues Rep. Bierlein and Fitzgerald mentioned, interstate compacts are designed to have a common set of licensure requirements so that therapists can practice seamlessly from state to state without delays. 31 other states, and I will say that I looked up the number I reported on when we gave testimony last term, it was 26. So just in the last 2 years, 5 more states have joined, and I hope Michigan's not going to be the last one. So 31 other states have successfully joined the Interstate OT Compact. And as was stated, this can help military families. So we talked about members of the military, but oftentimes they're what's referred to as their trailing spouse has difficulty with work. And so I want to emphasize that both the military member serving, but also their spouses can be helped by compacts. It was also stated that, the border states like Indiana, Wisconsin, and that other state down south that we don't name can be helped by these types of reciprocity situations. And it really can eliminate some of the costly burden of having a separate license in every state. Occupational therapists are also already undergo significant education to practice in their field, and these highly educated professionals will make decisions about where to practice and live based on accessibility and based on the compacts, whether states are in it or not. And I will say again, anecdotally, someone asked about the number. We can probably look at that specifically for OT2, but I have had several of my own residents in Kalamazoo who are attending Western Michigan University specifically say that they are looking at other states and leaving our state because we are not a compact state. So I really appreciate the chair taking these up again, and we'll take any questions. I do want to touch on, and I think Denise Hoffman, who's going to be speaking as an occupational therapist herself, she can probably address this as well. But in terms of the jurisprudence question, I do know that both PT and OT must follow all the existing laws in the state for that profession. And so my understanding is that the jurisprudence exam would have to be taken. Thank you.
Thank you, Representative. We do have a question from Representative Thompson.
Thank you, Mr. Chair. And thank you, Representative Rogers. First of all, I have to say that I think having you as a physical therapist and Representative Bierlein's experience with physical therapy also, one thing that I wanted to know if you could tell other members that aren't involved in healthcare. So I have 2 questions, if that's okay.
Absolutely.
One would be, can you tell them the difference between an occupational therapist and a physical therapist?
Yes, great question. So basically, and I think Dr. Denise Hoffman can probably touch on this too, but occupational therapists have a lot of different areas of expertise, but their focus is usually on activities of daily living. So things like toileting, bathing, dressing, all those things that you need to be able to do the tasks that you do throughout your daily life. That's kind of their specialty. They also have subspecialties like hand therapy. Physical therapists tend to be movement specialists. Oftentimes in the hospital, there's an understanding between the 2 interdisciplinary teams so that there's not duplication in services. And so In hospital settings and acute care, oftentimes physical therapists work on the lower half of the body, so they'll work on leg mobility, and sometimes it's divided into upper arm things for the occupational therapist, but that it's really discipline, team specific, and there's a lot of other minutia, but that's kind of the overall.
Thank you. And then also, I loved how you talked about your part and your role in discharge planning and how important that is for hospitals and long-term care facilities, rehab, and so forth. And then you also, in your testimonies, you've also let us know that your husband is also a physical therapist. So I think now that we have legislators that are working in healthcare and understanding how this legislation affects their practice, affects the healthcare setting, affects patients, and these compacts are really geared towards bringing talent to Michigan and keeping that talent in Michigan. So can you tell us a little bit about how this would have affected you? Say your husband got an awesome job in one of these compact states, and you wanted to join him, but would have to renew your license. Can you tell us a little bit about that?
So I'll just briefly say from my own experience, I moved out of Michigan when I first graduated because there was a shortage of jobs in specifically Southwest Michigan. There were many hospitals that put a hiring freeze in place because of some congressional action and some new rules that happened at the federal level. And so I moved to Texas for my first job, but I looked at when I moved back to Michigan because I wanted to be in the greatest and best state in the country, also my home state. I looked at compacts because I was trying to decide if I was going to maintain my Texas license as well as my Michigan license, as well as where I went to school, which was in Wisconsin. So that became, as a newer graduate, a financial burden, and so I chose not to keep up the licenses in all those multiple states. Had the compact been in place, I certainly would have wanted to participate in something like that.
Thank you, Representative.
Thank you, Representative. Any other questions from the committee? Seeing none, we'll move on to our next speaker. And appreciate you being here and supplying treats for the committee. You're trying to bribe us or something. So next we have Denise Hoffman, Legislative Chair of Michigan Occupational Therapy Association, as well as Dan Logson, the Council of State Governments via Zoom. We got one on Zoom and one not, but Denise, we'll let you start whenever you can. If you can make sure your mic is hot, the testimony table is yours.
Great, thank you. So thank you, Chair Vanderwall and the Health Policy Committee members. My name is Denise Hoffman, and I am a doctor of occupational therapy, and I'm board certified in pediatrics. I'm also the Legislative and Advocacy Director for the Michigan Occupational Therapy Association. I teach adjunct in higher education, and then I work in the school system. And I will share a little bit that I do live in one of the border states and my role in looking at the compact. So I am here to testify in support of House Bill 4103 and House Bill 4104. I will condense because we've already heard a lot of duplication, and I will just try to highlight how it's specific for OT so we can get more of a wide vision of why this is necessary. I would like to express my appreciation for your past support and also for your current consideration of the Occupational Therapy Licensure Compact, or the OT privileges. This is a measure jointly with the American Occupational Therapy Association and the National Board of Certification in Occupational Therapy. So briefly, as we heard from Representative Rogers, occupational therapy is a profession that serves the community across the lifespan, addressing deficits with activities of daily living that require fine motor, visual motor, strength, coordination, range of motion, and sensory processing skills that may be infected or impacted by illness, condition, or injury. So the OT benefits for Michigan. The OT Compact will improve access to occupational therapy providers in rural areas and shortages, as we've already heard. This is reporting up to 8 months waiting period, for example, for infants and children with feeding conditions that go home from the hospital. They're having up to 8 months waiting period to get a qualified occupational therapy in rural areas or in areas that need a specialty feeding therapist, resulting in feeding tubes and alternative ways to maintain their health and wellness. Another example how the OT Compact can help Michigan. It increases equitable access to care, especially for the specialty areas, as we've already heard about, regarding hand therapy and other areas of specialty for occupational therapy, such as lymphedema care, conditions that impact work, impact getting out into the community. It also facilitates alternative methods of service, such as telehealth. This is an ideal practice for families that have limited access to transportation and also for families that have critical care conditions. Also, telepractice or telehealth may increase employment opportunities for Michigan residents to stay living in Michigan while be able to providing secure income and employment through telepractice through the OT Compact in other states. The OT Compact creates an alternative path to licensure for compact privileges, helps to hold their change in primary state of residence while other individuals are moving. As we heard, snowbirds, we could still provide that continuity of care through this privilege. The other thing we have already heard about, and I'll emphasize again, is our military families and their spouses. So this helps to decrease the financial burden the spouses could start to practice immediately instead of waiting for their license in Michigan to process, which at sometimes can take up to 6 months. The OT Compact preserves the regulatory authority of each compact state and protects public health and safety throughout the existing contact regulatory structure. And just briefly, we wanted to emphasize, unlike the national licensure initiatives that supersede state regulatory authority, Interstate Occupational Therapy Licensure Compact allow a member state to continue to determine the requirements for that state, as well as maintain that state's unique scope of practice for all members in that state. Currently, we've heard there are 31 states who have passed the licensure. There's 11 states that are pending, and we've heard our 3 border states have already passed. Ohio was the first, and then we have Indiana and Wisconsin. And I just want to close briefly stating back to my personal experience with the compact. I live in Michigan. I live close to the Indiana border. I currently maintain Indiana and Michigan license, and I have for over 8 years. I practice in-person and telepractice in Indiana for youth with recovering from sex and human trafficking. So that's a specialty area of telepractice that I provide through mental health. And then I work here in the school system where there's enormous amount of shortages with increase in special education needs in our community. I thank you for your time and your consideration to support House Bill 4103 and House Bill 4104, the OT Compact protecting quality of care and access to services. Thank you, and I'd be willing to answer any questions that you may have at this time, or if we would like to go to our other speaker.
I think that we'll ask the committee any questions. I have one, and I picked up out of your testimony, is 6 months that it could take up to get licensure. Is that unique to Michigan, or is that a kind of a standard throughout the region?
I can't answer that exactly. What we have, I do know that from Michigan, and we know that from an experience with a current person moving to Arizona. So because there's a little bit different with continuing education, so what the license board sometimes will audit and want extra paperwork to verify that you've had that training, or you would have to provide more content to that training, and that takes time. So I only can speak about the state and Arizona. Well, actually, I can speak, it did take me about 4 months in Indiana to resume some things.
All right, very good. We do have a question from Representative Preston.
Thank you, Chair. Because I want to applaud all of you for all of this. Increasing capacity is a big deal, especially border communities across the country. So regarding some of these jurisprudence exams, as well as the continuing education aspect, so if you're in the compact, does the host state then bear the burden on the continuing education, or are they going to need to comply with both states' continuing ed requirements? And then on the jurisprudence exam, is it going to be limited to the public safety aspects regulated to the state that they're seeking entry into, compact-specific data, disciplinary data, and state-specific scope of care laws? Or are we going to go into, and you know how how these exams can go. They can go into actually what would be more of a continuing education aspect and become really just a drag on the entire system and on the practitioner's ability to move freely with the compact and use the compact, as it's intended.
Right. I will give an example of what Ohio, which was the first state to sign into the compact, they have an exam. If we have compact here and I want to work in Ohio, then it's a modified, and it's a statement that I read and assures that I am taking ethical responsibility to understand and review what their continuing ed requirements are. So it's a modified. They call it an exam, but it's a statement, and then you state that there hasn't been like an audit yet. But that's what Ohio is doing, and other states are looking to model that.
Very good. Thank you very much. We'll move on to our next person is Dan Logston from the Council of State Governments. Dan, the table is yours, and thank you for being here today.
Thank you, Mr. Chairman, and thank you, members of the committee. I don't think I can add a lot to the last two bills that were reviewed. I was asked to come today to answer any questions. Just briefly, I'm the director of the National Center for Interstate Compacts. We've advised on all of the current licensure compacts that are out there, and we're working very closely with the OT compact. And again, don't want to belabor anything. Happy to answer any questions. Don't have much to add. The two prior bills have had, they've exhausted a lot about these compacts and how they work.
Very good. We appreciate that. Any questions from the committee? Not seeing any questions. We thank you very much for being here. And you got off easy today, so thank you. With that, we have a few cards to read in. Julie Myresta, Ascension Health, not wishing to speak in support. Not wishing to speak in support, Taylor Elpert, Michigan Health and Hospital. Not wishing to speak in support, Concordia University OT program. Not wishing to speak in support of 4101, 4102, and 4103. Jason Lakowiski, ARP of Michigan. Not wishing to speak in support, Scott Kempa, Michigan Association of Health Plans. Not wishing to speak in support of all the bills, Brett Jackson, Michigan Health. And I believe that is all. So thank you all for that. Representative Schmaltz moves to excuse absent members. There being no objection, the motion prevails on unanimous consent. There being no further business before the committee on Health Policy will stand adjourned.